Welcome to the Prostate Cancer in Times of the COVID-19 Pandemic event. I am Phyllis Ellis, president of the Brockton area branch NAACP, and I will be your host for today's event. A little history about our branch. The Brockton area branch NAACP was chartered in 1954. We have close to 200 members, and we are always looking for new members. Our mission is to ensure the political, educational, social, and economic equality of rights of all persons and to eliminate race-based discrimination. Our mission brings us here today to talk about prostate cancer, a disease that discriminates against African American men. Our branch has been partners with Dr. Stern and the AdMeTech Foundation and Lynn Cornelius and Good Samaritan Medical Center for the past 6 years. Dr. Stern sought out Brockton because at the time, Brockton had the highest rate of African men dying from prostate cancer. Those numbers have improved over the years. I believe it is due in part to the prostate cancer awareness events we host 3 times a year. Education about this disease can save your life. We have very distinguished people here today, very distinguished panel. Today, all here with the goal of addressing your questions and concerns about what is the status of the COVID-19 pandemic in Brockton and related community resources? What can you do to protect yourself and your family? How do you take charge of your prostate health in the face of the pandemic? And what are the cutting-edge advances in prostate care? Our panelists are here to answer those questions and more. And if you have a question for the panelists, please put it in the chat box or use the Facebook link. We had some distinguished other guests, but they're not here at this time. So we're going to move on to our program. Up first is Michael Curry. Let me introduce you to Michael Curry. Michael Curry Esquire is the president and CEO of Massachusetts League of Community Health Centers. He's here to give us an overview of structural racism and its impact on health disparities in COVID-19 and prostate cancer. Mike, are you ready?
Yes, absolutely. President Ellis and all of the attendees, the other panelists, it's an honor and a privilege to join you in yet another conversation in Brockton, which I think, quite frankly, President Ellis has been the epicenter for having these critical conversations around race, around health equity. And I get the honor and privilege of traveling the country virtually now to have these conversations, but no other community, I think, is above what Brockton is doing in this space, particularly around health equity and prostate cancer. I would say, just to sort of open us up for a conversation today, it shouldn't have taken us this long. With the murder of George Floyd, with a pandemic that, quite frankly, took too many Black and brown lives to get to this moment that we realized we should have had a conversation around health equity and racial justice. I'm preaching to many in the choir who've been doing this work a long time, but for all those on the line, it shouldn't have taken a pandemic to realize that those closest to the pain would be closest to the disease. That if you are food insecure and housing insecure, if you don't have the resources to stock up on food, if you can't work remotely, whether it's Katrina or COVID-19, you are more likely to be infected, hospitalized, and die. That is no surprise. It should be no surprise that a year after George Floyd's murder, we're now having a reckoning on police violence. We should know about police violence that goes way before Michael Brown and Tamir Rice and Breonna Taylor and Sandra Bland, because activists like NAACPers, President Ellis, have been raising this flag since that sign flew on the front of that New York building in the early part of the 20th century that says a man was lynched today. And it gave birth to the movement that is now the NAACP. We were fighting against the fact that Black lives didn't matter for hundreds of years under slavery. We were fighting for the fact that Black lives didn't matter for much of the 20th century and arguably don't matter today. And people always ask me, why do you say it doesn't matter? Well, I said, well, all the data tells us it doesn't matter because we die almost of every disease at a higher rate. We don't have the same access to healthcare. We're uninsured at higher rates. We're incarcerated at higher rates. We're Our rights are violated as we walk around department stores or drive down the streets at higher rates. Our murders don't get solved. So now we're having this conversation today around prostate cancer and health equity. I want to lift up, we talk about racism, systemic racism, Victor, that it's not just about people stripping over stereotypes, right? We know that some people carry implicit bias, they make bad choices, right? Whether you've done your homework or not around Jane Elliott's eye color experiment, or you've watched some key documentaries or read some good literature on this to get context for racism. The reality is that people carry racial animus in their hearts too, that they know what they're doing. And their doctors, their lawyers, their judges, and I would argue in the most recent election, they voted their politics, they voted their racism, millions of them. So when we talk about prostate cancer and health equity, we have a challenge. We have to reach those allies who want to do something around getting people access to good quality health care that saves their lives, that diagnoses their prostate cancer early, that prevents that cancer. But we also have the underlying issue of health equity that results in too many of us experiencing shorter lifespans, being able to save, less money, not raise our grandkids, not build political power and voting power because we're gone too soon. And again, I think it's critical that we understand this issue of racism. It's pervasive. I use the line from the movie Sixth Sense. The little boy says, "I see dead people." And he didn't want to see dead people because he understood that if he saw dead people, he'd have to answer their call to resolve their unsettled murder or the loved one they didn't get to say goodbye to. So it was easier not to see them. And I think we as a generation don't want to see racism because it can mean you lose a friend, or you don't get invited back to the meeting, or you get labeled a militant, or people just don't want to listen to you. So that's the work that AdMeTech and NAACP and many other allies in this work have been doing for a long time. Ms. Martin is really speaking up and speaking out and taking the risk to challenge authority and institutions to give us better healthcare. Last but not least, President Ellis, J. Marion Sims in the late 19th century experimented on Black women. Anarcha, Lucy, and Betsy, if you don't know their names, say their names. That was just an example of the experimentation that happened on Black women and men, like Auschwitz and Dachau, when we talk about Jewish men and women under Holocaust. You had decades of Tuskegee syphilis experimenting on Black and brown citizens without treating for their syphilis, when there was a treatment for syphilis, as there was care that Anarcha, Lucy, and Betsy should have received, and they didn't get that. Or the Institute of Medicine's 2002 report of unequal treatment that validated what those activists have been saying in neighborhoods like Brockton and Roxbury, that white folks don't treat us the same. We go to get our medical care. Now it took the Institute of Medicine to validate that in a 2002 report. And then the Black woman who died at the end of last year of COVID-19, the physician who lifted up the message that she didn't get the care that she needed in a timely way, and she died. So we have a past to reconcile with, and a present and a reality and a lived experience to address as well. And I'm just excited to be here tonight as we have this rich conversation around what is killing way too many Black men, which is prostate cancer.
Thank you, Mike. Appreciate that. I would like to take this time to acknowledge churches that are here. We have 5 churches here with us this evening. So we have Mount Moriah Baptist Church. It was established in 1981. The senior pastor there is Reverend Cedric C. Rucker. We have Lincoln Church Ministries. Pastor Houston Creighton is the pastor there. He's been pastor for 35 years, and they gathered in 1897. One of the oldest churches here in Brockton. We have Messiah Baptist Church. It was established in 1897, and the current interim pastor there now is Reverend Dr. Michael Friday. We also have New Jerusalem Tabernacle Prayer for All People. The church leader, Apostle Ed Campbell, and it was incorporated in 1986. And lastly, we have Full Gospel Tabernacle Church. The name of the pastor is Reverend Ortiz Vandross. He's the senior pastor there, and it was established in 1953. So thank you all for attending our event this evening. Next up, we are going to hear from Dr. Richard Herman, who's the medical consultant to the mayor's office. Dr. Herman will provide his perspective on the current status and metrics of the COVID-19 pandemic in Brockton and the importance of vaccinations for ending this pandemic. Dr. Herman, you are up.
Thank you, Phyllis. I appreciate it. Thanks very much for inviting me back. For those of you who don't know me, I'm Dr. Rick Herman. I've been an emergency physician in Brockton for the past 40 years, and Mayor Sullivan asked me a year ago to serve as a consultant to the city to help get through the pandemic. So let me bring you up to speed on where we've been and where we are now. We are on pandemic day 461, so since March 14th of 2020, when our first case in Brockton appeared. This is a heat map of the city of Brockton, where the cases tend to occur right down the central corridor of the city, and that correlates to a lot of uh, uh, social determinants of health, such as elderly, no internet, not non-English speaking. This map just happens to show the percentage of households with no internet, and kind of correlates where the COVID cases have spread, and all the social determinants of health seem to reflect the same areas in the city. Especially Brockton's share of frontline workers. Out of the top 100 cities in Massachusetts, Brockton ranks first in terms of the number of frontline workers. And as you might imagine, those are the ones most vulnerable to getting COVID, which explains the very, very high rate of COVID in Brockton compared to other communities in Massachusetts. This is the history of COVID, what it's looked like over the past year plus. Our spike last spring, our spike over this winter, and now over the last several weeks, thankfully, COVID seems to be disappearing. And I don't want to say disappearing going to zero, but certainly going down to background status, so that whereas we had over 100 cases a day of COVID at the beginning of the year, now we're down to an average of closer to 3 cases a day that are appearing. Likewise, the positivity rate at the very beginning of the pandemic was up where 40–50% of the cases we tested. And at the beginning of this calendar year, we were over 10% of the cases. And over the last month or so, our test positivity rate has dropped now to below 1%. But from my perspective, that's not really what's important. What's important is, are people getting sick? Are people getting hospitalized? Are people in the ICU? Are people dying? Because we don't really care if COVID was just a bad cold, no one would notice it. But the fact that 600,000 Americans have died, we notice it. And this is what the hospitalization rate in the city looks like since the beginning of this year. Between both hospitals, we're up close to 100 patients combined in both hospitals, and now that's plummeted down to the single-digit number of patients. And why is that important? Because the CDC looks at this as a metric for how severe COVID is in the community. And in our community, if 15% or more of the hospital beds are populated with COVID patients, that's really bad in a red zone. If fewer than 5% are populated with COVID patients, that's good, and the green zone, and that's where we are now. Less than 5% of our hospital beds now have COVID patients. Likewise, this is looking at a weekly death toll in the year 2021. And Brockton has had a total of 434 deaths since the beginning of the pandemic, but none in the past 4 weeks, which is really quite astounding and speaks volumes to the efficacy of the vaccine. Every day, if you go to the city's website, you can see a dashboard of where we are. This is today's dashboard, and it reflects data as of 5 p.m. tonight, which is every Thursday when the Department of Public Health releases its vaccine data and daily counts. Now, as I said, our number of average daily COVID cases is 3.2. Our test positivity rate is under 1%. We have 26 active cases currently in the city. That was up in the 300 to 400 range just a few months ago. And as you can see, only 6 patients combined in the 2 hospitals. Uh, Likewise, the cities and towns the towns surrounding us likewise are doing just as well, if not better, in terms of their number of cases per day. You can see everyone is either in the green zone or the gray zone. The gray zone meaning the smaller towns having less than 10 cases over a 2-week period. So if you take all the towns that touch Brockton and look at what their average is, it's an average of about 2 cases a day that we're seeing. This is a vast improvement over where we've been. So I don't want to say that COVID is gone, because I think it is still out there. And right now, that the virus and its various variants want to win, and the vaccine and vigilance, we want to win. And so as of 5 p.m. tonight, this is the data of what Brockton looks like. The blue bar represents the age groups of those, the population in the city, and the green bar tells you how many of those residents have gotten vaccinated. As you can see, the older population has done a pretty good job of getting vaccinated. The younger population, not so much. If you want to look at it a different way, we look at it people over 50, and you can see that 80+% of those over 50 have started the road to vaccination with at least 1 dose. Under 50, only 37%. So why does that matter? Well, this is why it matters. On the right-hand side, these are the people that got the vaccine. On the left-hand side, these are the people who are getting the disease in the last 3 months. People that have gotten the vaccine are protected. People who have not gotten the vaccine, well, they get COVID. So it's so important to make sure that everyone who is eligible gets the vaccine. And we are trying to reach out to various communities. The Department of Public Health breaks down Brockton in terms of race and ethnicity, looking like this. And when we look at the amount of vaccines, for example, if we look at the those that identify as Black, we see that is 50% of the population. If we see the percentage of those that have gotten the vaccine, you would expect 50% of the population to have gotten it, but it's 38%. Now, I know it's a little tricky because the state does not break out Black and Cape Verdean and Haitian and break it down by ethnicity. So we're not quite sure, but we do know that that in our community, Haitian population, Black community, African American community, Cape Verdean community are our targets for reaching out. So what's next in terms of vaccination? Well, if you look at it pessimistically, you can see this is the population of Brockton. And this is how many people have been vaccinated, either completely, fully vaccinated or partially vaccinated. And this 47,000 is people who have not gotten a vaccine. And that looks like a pretty big number. But I prefer to look at it a little bit more optimistically in terms of immunity, because we want the population of Brockton to be immune. And so how do you get immune? Well, you either get the shot or you get the disease. Either way, you have some kind of antibody and protection. And if you look at this thermometer, you can see 14,000 have gotten the disease or probably had the disease. 51,000 have gotten the shot. And of the remaining folks, a big chunk, 16,000, can't get the vaccine yet because they're under the age of 12, which really only leaves this 15,000 as the target population who we really, really want to make sure get that vaccine. Just another way of looking at it. Over a little over half of our community has received some vaccine, and it's this 16% that we really want to target to make sure that they get vaccinated. So what's next? Well, I feel very, very optimistic that we will remain in the green zone and in fact, maybe even get to gray. Less than 1 patient a day would get us to gray. This summer, there's absolutely nothing to make me think that the population, that the disease is going to spread. Last summer, we did pretty well with the disease. COVID doesn't seem to like the summer when folks are outdoors. And we are going to continue to vaccinate. The city of Brockton, through the mayor's office and the Board of Health, is going to continue to have clinics. We will have a standing clinic at the Shaw Center on Thursday and Saturday. We will have mobile clinics throughout the city. And we're working with the Department of Health to identify those areas in the city that have not gotten their vaccines, and we are going to do door-to-door canvassing and encourage people to get vaccinated. It's very important that folks follow through and get their second shot. Why? Because of this Delta variant. So there's a variant of COVID that's out there spreading like wildfire around the world and now in this country. And it really takes, the bad news is it's spreading. The good news is that the current vaccines are effective against this variant, but you need to get both doses in order to be fully effective against that variant. So that's why we're encouraging people not only to get the vaccine, but to make sure they follow through and get the second vaccine as well. So that is my update on COVID in the community.
Well, thank you, Dr. Herman. I see we have another special guest who just joined us, and we'd like to acknowledge her, Representative Michelle Dubois, who is a champion of the Prostate Cancer Educational Program. Michelle, you want to say a few words?
Hi, everyone. I'm sorry to be late. Thank you, Phyllis, for having me here to be with the NAACP and support the efforts that you're doing so great with AdMeTech, and hearing from Rick Herman about our status here in Brockton is always educational. I did a lot of screenshots through your presentation, Dr. Herman, and I really appreciate the breakdown of the number of people of color that have gotten shots, and then the number of people that can't get shots. Young, just really showing us that Brockton is doing pretty well. There's a lot more to be done, but the city has done, and to some extent the state has done a really good job with a lot of pressure and a lot of pushing to make sure that we get the resources here that we need. And I know that's something that we all have in common here. Prostate, I think I was here to talk about prostate cancer, but I don't know where we're at on the agenda. So hello, everyone, and I'm happy to be here.
Thank you, Michelle. Next up, we're going to have Dr. Fain, President and CEO of AdMeTech Foundation and an outstanding partner with Brockton NAACP. Dr. will provide transition from COVID-19 to prostate cancer by addressing emerging advances in COVID-19 care and control, with emphasis on hesitancy related to vaccinations and the importance of a continuous prostate cancer care in the face of COVID-19 pandemic. Dr. Stern, you're up.
Thank you so much, Phyllis. Actually, Ali and Thomas helped me prepare a brief video, and we'll proceed with the video. I also am listening to this conversation. I'm thinking about my conversation with Dr. Kwok Din Trinh 5-6 years ago. And I was listening to and I was thinking about that conversation, and we were looking at the disparities in prostate cancer, disease that is curable when detected early. And I would never forget how Kwok said that this looks like human rights issue. Ali, if you could please help with the video.
I would like to express my gratitude to Brockton NAACP and Good Samaritan Medical Center for your partnership in organizing this event. Our event today is a part of the ongoing program in prostate cancer awareness and education in Brockton and Plymouth County since 2015, with primary focus on Black men. This program is made possible by members of the Brockton delegation to the Massachusetts State House, who have been our legislative champions, including Senator Brady and Representatives Cronin, Cassidy, and Dubois. Both COVID-19 and prostate cancer have emerged as leading health disparities. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities, including Brockton, directly overlap with the pandemic hotspots. Since May last year, we have expanded our program to include education about prevention, diagnosis, and treatment of both prostate cancer and COVID-19, as reflected in this event. Prevention and early detection are critical for eliminating disparities in both prostate cancer and COVID-19. Dr. Herman already addressed COVID pandemic in Brockton and the importance of vaccinations. Vaccination is the best tool we have for preventing COVID-19 and ending this pandemic. Currently available COVID vaccines have been proven safe and effective in millions of people. Vaccines prevent infections, severe disease, hospitalization, and death in countless people. Complications are extremely rare. Recently, Dr. George Abraham, expert of infectious diseases at UMass, pointed out that we are much more likely to get into a car accident and related serious injury than develop any complication from COVID vaccines. Vaccines are the best way to protect not only ourselves, but also our families and our communities. By accepting vaccinations, every individual help us get one step closer to ending this pandemic and being able to see our families, friends, and co-workers safely. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection, which save lives. Screening and early detection are particularly important for Black men who are 2.5 times more likely to die of prostate cancer compared to white men. When we started our prostate cancer educational and awareness program in 2015, African American men had the highest prostate cancer mortality in the state. It was much higher compared to state average. By 2021, we've seen more than 50% reduction in African American mortality in Plymouth County. And now it is significantly lower compared to state average. Between 2015 and 2021, we've seen significant reduction in disparities in prostate cancer mortality between Black and white men in Plymouth County. In sharp contrast, during the same period of time, Massachusetts has not seen any differences in prostate cancer disparities. In summary, prevention and early detection save lives and reduce health disparities in both COVID-19 and prostate cancer. Large-scale vaccination resulted in sharp decline of the pandemic, but we are still in the race between virus variants and vaccines. Doctors Fish, Trink, and Frankel will address the latest advances in prostate cancer care and the importance of screening, early detection, and treatment to save lives. Education and awareness reduce health disparities.
Thank you, Dr. Stern. I understand that we have another special guest here, Senator Brady. Senator Brady has been an advocate for us for over 6 years, and we really appreciate what he's done for us. So, Mike, you want to say a few words?
Sure, thank you, Phyllis, and I'm happy to be here. We've had a busy day today, had an economic development meeting, and that ran 6 hours long. Then I had a couple other meetings earlier tonight, so I arrived late myself. But in the budget, we were able to work together to get more money for prostate cancer awareness and to address the issue. It is in a conference committee now between the House and the Senate. Hopefully, we'll be getting that done soon. As was mentioned, the effects of prostate cancer within our community, especially in Plymouth County, has been through the roof. And I want to thank Dr. Stern. My fellow colleagues in the House were on this committee with Dr. Stern and Steve Bernard and the group from the NAACP. We've been meeting for quite some time to address this issue, to make awareness of it, which is the most important thing, because especially our district has affected us tremendously. So, and we've had some guest speakers that have came before us to talk about prostate cancer awareness and to get the word out to get tested, because it's the numbers are through the roof in our area here. So I'm glad for all the work everybody's done. And I want to say hello to Michael Curry being on here tonight. We haven't seen him in a while than when he's on the TV with the governor, but we miss you, Mike. And anything we can do moving forward to help out. I have all the numbers and the statistics. I don't want to beleaguer everyone's time tonight regarding that, but we are still staying on top of things. And Dr. Stern has led the way with Steve Bernard and Phyllis as well. So please let us know whatever else we can do at the state level. Thank you.
Thank you, Mike. Now we're going to hear from the Mayor of Brockton, Mayor Sullivan. He will provide his perspective on COVID-19 pandemic in Brockton and why he supports prostate cancer awareness during this pandemic. Mayor Sullivan.
Good evening. Good evening, President Ellis. Always great to see you. Great to see Mike Curry. Both Phyllis and Mike are just great Brocktonians, and they've both volunteered to serve on the Community Justice Task Force, and they are just exceptional citizens and folks, and I just have so much respect for them. I really am honored to be here. We've been on many of these calls. I want to thank the NAACP and, of course, Dr. Stern, Dr. Fish, Dr. Frankel, and Dr. Rick Herman, my medical consultant. So when I became mayor on January 6th of 2020, COVID-19 was over in Europe. At that time, it had gone over to Italy. And my wife, being a physician assistant, had said to me, hey, Bob, as mayor, you might want to consider this. And we did. We had a task force roundtable upstairs at City Hall. About a week later, it came to the shores here and the West Coast. And, 6 weeks later, it was here. As I sit here now, 434 residents have perished because of COVID-19, and a high percentage of those are our minority residents here in the city of Champion. So, I think there's an idea right now that COVID is gone. COVID is not gone. Thankfully, we've gone from a red to a yellow to now green, but we need to continue to be diligent and vigilant. That's what we need to do. Dr. Herman and Dr. Eno Mondesir, who heads up our Board of Health, and Steve Hook, who heads up our Brockton Emergency Management Agency, we have a call every single day at 10:45 to talk about what are we doing well, what are we not doing well, what can we do better. The outreach with the Health Equity Task Force that I set up over a year ago has been exceptional. Our DPH partners and our liaison here in Brockton that speak multiple languages, reaching out to all aspects of the community of Brockton is extremely important. I will tell you that we have a call with the pastors every Wednesday at 1 o'clock. High percentage of the pastors that join the call are Haitian pastors. There are a lot of misnomers and rumors and falsehoods in the city right now, and in the Commonwealth and in the country. People are on the belief that if you get the injection, you're going to have a microchip put in you, and your DNA will be changed, or you will become sterile. We had to educate our middle school students, and I want to just tell you that the city of Brockton has always been ahead. And we had a vaccine clinic roll out at Brockton High. It hadn't happened in any public school in the Commonwealth, and we did it, and we did it exceptionally well with our partners at the Brockton Public School, school nurses, and again, Board of Health. But we continue to do that. We just did the second Pfizer shots of the middle school the other day. 800 boys and girls rolled up the sleeves, took the shots, saved their own lives, and protected the health of their family members and loved ones. So, I am a huge proponent of educating. To be an effective leader, you have to listen and learn. And I listen and learn from Phyllis and Mike Curry without question. We need to continue to stress the importance of educating so that, 51% of our population have taken the shot. We need to do much better than that, to be frank, ladies and gentlemen. We need to do it. It's that important. So I'm here also as the son of a prostate cancer survivor. My dad was detected, and thanks to Dr. Zolls, my dad is still with me. He turned 81 last Sunday. So I know that through the education of the NAACP that our African-American men get it at such a high, staggering amount compared to white people. So we need to continue to educate, inform, and also make sure that there is no embarrassment. I'm a guy, right? So guys get embarrassed for the prostate exam. You need to do it. It saves your life, okay? Do not hesitate. Do it, do it, do it. Again, Phyllis, I just want to thank you so much for always doing what you're doing. I always say you're the Energizer Bunny, and I say that with the utmost respect. So keep going and do what you do.
Thank you, Mayor Sullivan. I really appreciate that. Next up, we're going to hear from Dr. Fish. Dr. Guy Fish, he's a healthcare strategist and innovation specialist. He would give us his general clinical perspective on prostate cancer, screening and early detections as the means of reducing health disparities. Dr. Fish, are you ready?
Thank you, Phyllis. I really appreciate the opportunity to be here today and speak on prostate cancer. So thanks to the NAACP, thanks to AdMeTech, thanks to all our elected representatives who are supporting the efforts to eliminate this health disparity. These health disparities that we've been talking about and which Mr. Curry spoke to, I want to be clear that these aren't things in the past. When he mentioned James Marion Sims, when he mentioned Tuskegee, these health disparities and the inequities that happen when the medical establishment interacts Black and brown bodies still go on. In fact, no less an esteemed institution than Columbia Medical Center and Mount Sinai in New York, as recently as 1998 and 99, conducted a study in New York. How many people remember that magical potion that was supposed to keep us from being fat called Fen-Phen? Anybody? Yes, right. Fen-Phen was supposed to be this magic combination of two drugs. And one of them, turns out, unfortunately caused heart problems. But that didn't stop the researchers in 1998 from reaching out to communities in New York, and where there were two boys, one who would be incarcerated and a younger brother, injecting the younger brother with the not so good drug, phentermine, to see if it had a result on reducing what they presumed was going to be violent behavior in Black boys. That study was shut down. But the fact that it happened at all, and particularly in 1998, gives you reason to believe that A, we're not making this up, and B, it still goes on. So we have to be ever vigilant with respect to how the medical establishment and Black communities and brown communities interact. And so when we're talking about rates of vaccination, which there's been lots in the press about vaccine hesitancy in Black communities, it's with good cause. We've been down this road before, where they tell us one thing and they're doing something else. But at the same time, we also know that we are more exposed to threats to our lives and our livelihoods because of our livelihoods. Many people in Black and brown communities are not employed, as Mr. Curry said, in occupations where they could work from home. If you're a bus driver, if you're a healthcare worker, you are on the front lines every day. So we have to balance both of these things, and we're capable of doing that. But also to be mindful of the fact that it's just not Black and brown communities that have had some resistance to vaccination. If you go to Trump country, there's a lot of resistance to it there, and those are for very different reasons. So as to prostate cancer, I have three things that I'd like to go over with you today. The first is that prostate cancer, particularly in the African American community, affects all of us, not just some men. Number two is that by not addressing it, the impact can be devastating. And overall, as African Americans, we have not been addressing it well. There are few communities that are as engaged as Brockton is in the work. And so kudos to Brockton. But there's more work to be done. Number three is that there are new tools and methods to change our experience with prostate cancer. And I speak to the experience because it does not need to be a death sentence. So let's go over those again. Number one, prostate cancer affects us all. As Mayor Sullivan said, he has had an experience with his loved one, his father, with prostate cancer. If I were with you in a room, I would ask everyone who's had someone in their family with prostate cancer, a man in their family with prostate cancer, to raise your hand, and I would raise mine too. My dad, John Fish, was a chemist. His dad, Frederick Fish, was a schoolmaster. My mom, Juanita, is a nurse, and her mother, Martha, was a domestic, as we used to say. I grew up in Cleveland with 3 sisters, and I was very competitive with them. And my sister, Deborah, decided to go to an exclusive girls' college, and so I had no choice than to try to one-up her by going to Harvard. Attending Harvard was not easy. As W.E.B. Du Bois said, he was at Harvard, not of Harvard. And I felt that experience. But God is good. And after finishing there in science, I attended Yale Medical School. And while I was at Yale Medical School, I got the call none of us are prepared for. Despite studying medicine and disease and even cancer, I can still remember getting the call from my dad telling me that he had gone to the doctor and found out that he had prostate cancer. I know personally how hard it is hearing that. Fear, doubt, betrayal, sadness, compassion, it's all there. The entire family goes through that. That's what I mean by it's not just the men, it's all of us. And then we lose some of these men prematurely. My family story is one of good news because by finding out about early and by my mother and me both being plugged into medicine, we took full advantage of the things that were possible. And my dad lived another 12 years before he went home. He saw 6 grandkids and had a good life. So at this point, again, it's important to ground ourselves in what are we talking about? Lots of us have said the word prostate and prostate cancer. So what are we talking about? The prostate is the small gland in men only. It's part of the sexual reproductive system. It sits under the bladder and in front of the rectum. And its job is to provide fluids, lubrication, and nutrients for sperm as they usher forth. So what is prostate cancer? Well, cancer occurs when the usual controls on the regenerative properties of cells are undone by some means. That means that instead of cells having a normal lifespan, they start acting as if they're immortal. Now, our body has natural defenses against this. In fact, we're all getting tumors all the time. And 99.999% of the time, our body handles it. But occasionally, control of those tumors is lost, and we get serious health problems from that. So prostate cancer occurs when some cells in the prostate gland lose their controls and start acting immortal. And any man who lives long enough is almost guaranteed to develop some prostate cancer. And since we either have fathers or are fathers or have brothers, it therefore, again, affects all of us. So, as I said, number one, prostate cancer, particularly in the African American community, affects all of us. Number two, if not addressed, the impact can be devastating. So, what is the number one cause of death for Black men? Well, it's not different than the number one cause of death for all men. And in fact, I'm going to share my screen here for a second with you and show you that cancer is the number 2 problem cause of death in America. Cardiovascular disease is number 1. So there's another conversation another day, Phyllis, about heart disease in Black communities, but we're talking about cancer, which is the number 2 cause. And among cancers, it's different for men than women because we're kind of built differently. For men or women, that blue is lung cancer. That's the number 1 cancer if you combine men and women together. Number 2 in men after lung cancer is prostate cancer. And then number 3 is colon cancer. For women, since they don't have a prostate gland, but they do have breast, number 2 for them is breast cancer. Number 3 is colon cancer. So clearly, we need to pay attention to prostate cancer, lung cancer for sure, colon as well, but prostate cancer in men is really significant. And as Faina said, Dr. Stern said, prostate cancer discriminates. Black men are 2.5 times more likely to die from it. And the question is, should be, why is that? What's going on with prostate cancer in Black men? The answer has a lot to do with whether or not we are screened. Now, 1 in 8 men will get prostate cancer. 1 in 40 will die from it. So clearly, you can live with prostate cancer. But the reason that the odds are worse is because of detection. If you look at the 5-year survival, that is, 2 men, both diagnosed with prostate cancer, which one of them is alive after 5 years? If you are screened early, there's almost 100% chance you detected it early, they'll treat you, you'll be alive 5 years later. If it's a late diagnosis, you arrived on the doorstep with some symptoms because you weren't screened earlier. 5 years later, your chances of being alive are about 28%. Now, which one do you want? Nearly 100% chance of being alive 5 years later, or a 72% chance that you're not going to make that graduation or wedding? I think all of us would like to be like my dad and get, at least 15 more years. But Black men are dying like flies because we're not doing something right now. We're not screening. So that gets to number 3. There are new tools and methods to change our experience with prostate cancer. Again, the fundamentals are screen, diagnose, and treat. And you have to screen with 3 components in mind: when to do it, how to do it, and what to do with the results. So when to do it. For prostate cancer, it's generally between 50 to 75 years of age, but there are 2 important exceptions. If you are under 50, you should be screened early if you are at high risk because someone in your family has had prostate cancer, or if you are African American or Latino. So, for purposes of this conversation, every man who's listening on this call or to this video on Facebook, if you're African American and 40 years of age, you should be demanding prostate cancer screening. So that's when to do it. How to do it. See your doctor. And as has been discussed by Mayor Sullivan and others, we get a little squeamish, us guys, about going to the doctor. This is where, again, all of us need to be in the picture here. We need the whole community, our wives, our mothers, our aunties, our sisters, to encourage us and make sure that we get to see the doctor and get to screening. There's a little bit of a problem because over the last 20 years, there's been some changes in thinking amongst the doctor community, particularly urologists, who are the ones that handle prostate cancer, about should you screen, shouldn't you screen, do you do a PSA, do you do a rectal exam, do you not do it? At the end of the day, after 20 years of going back and forth, the jury is back in. Go get screened. I won't get into all the details as why things got upside down about that, but go get screened. And then number 3 is, what do you do with the results? Most men will have a negative score. That's great. It's a little bit based on age, but that's great. But if it's positive, you need to do more to confirm the diagnosis. You need to have a biopsy taken, and then you need to have the biopsy results reported to you. Most will come back negative in the sense that it's not an aggressive tumor. But if it comes back positive, you need to then have that conversation with your doctor about treatment. The last thing that I'll say is that there are actually some interesting new tests that are being developed now beyond the PSA and the biopsy to determine whether or not your tumor is aggressive or indolent. These developments are part and parcel of what can be offered from a doctor to a patient. But sometimes bias in medicine comes into the picture. And oftentimes, if the doctor assumes that the patient in front of them has resources to pay for a test that is not covered by insurance, he or she may offer that test, and it provides another set of conversations and follow-up to happen. So because of that follow-up and conversation, your care is actually better because you're continuing to do shared decision-making about what to do with your prostate cancer. But the bias in medicine also says that if the doctor assumes that this man does not have the resources because of skin color, or assumed social economic status, that test may not be offered, which means that those follow-up conversations are much less likely to happen, which means that you get lost to follow-up and lost to care. And when you come back, your tumor, if present, may be more severe and further along. So this is how we have to eliminate bias in medicine. We have to have the conversations with every man, the same conversation, an excellent conversation about what the options are and what we can do for that. So to sum up again, prostate cancer, particularly in the African American community, affects all of us. If not addressed, the impact can be devastating, and we need to do more to address it by advocating for ourselves about getting tested. And we need to avail ourselves of the new tools and methods to change our experience with prostate cancer. So thank you very much for your time and attention. Again, thank you to our sponsors.
Thank you, Dr. Fish. Next on our program, we have Dr. Trin. He's an associate professor of surgery at Harvard Medical School, co-director of the Dana-Farber, Brigham, and William Women's Prostate Cancer Center, and director of ambulatory clinical operations at the Division of Urology Surgery at Brigham and Women's Hospital. He's here tonight to talk about prostate cancer expert perspective on emerging advances in screening and diagnosis of prostate cancer and their impact on reducing health disparities. Dr. Trent, you're up.
Hi, everyone. Hey, thank you very, very, very much for having me here. I'm really delighted to be here, to be participating and hearing about other experts talking about their work, and also, what's important to us here today, talking about prostate cancer. So I'm a urologist by training and trade. I mostly treat prostate cancer. And the topic today is really talking about innovations in access and screening and how they have impacted disparities. So I'm really going to focus on 5 points, I promise. And we're going to start with the first thing, which is screening. Dr. Fish talked about how important screening is and how important screening is specifically among African American men who are, as we know, more at risk of prostate cancer. I think it's really fascinating if you look at what has happened in the United States in the last few years. Is we've seen two things. Is that one, among communities of color, the education, the advocacy work that has been done has led to increased prostate cancer screening among African American men, for example. And probably equally fascinating, we also seen among white men a decrease in prostate cancer screening, among other things, because of all the confusion about the guidelines going back and forth and the potential problems with prostate cancer treatment. And the net result is that today, if you look at the data, there's actually potentially more African American men who are screened than white men, which is probably shocking to many of you because we have been working for so long about trying to get more African American men to be screened. Well, today we can tell you that it seems to have had an impact because that's what we see in communities now. But the work is not done, right? Because unfortunately, among men with bad prostate cancer, African American men are still, unfortunately, less likely to get treated. So there seems to be some sort of disconnect that today in 2021, African American men are potentially more likely to get screening, but there's something between screening and treatment, and something is lost. And probably and possibly a lot of our work should be now focused on, well, if you have an abnormal test, what happens afterwards? And how do you get the right men, the men who have bad prostate cancer, to be treated? That seems to be one of the big new challenges in the upcoming decade. So that's number one, right? Screening among African American men, among minorities. Number two, smarter screening. Right, and that I think is also potentially a huge innovation. I think that unfortunately in healthcare in America, this one size fits all model, and myself talking as a minority, an Asian minority person, is that when you do something one size fits all, it probably is true for the greater population. And in this case, in the world of prostate cancer, we're talking mostly about white men. It doesn't mean that it works for every single person. And I will give you some examples in a couple of seconds, but screening is probably one of them. If you make up guidelines for screening that are based on the general population, you're making guidelines for screening among white men, essentially. So when we say that the typical age is 55 to 69, finally, among experts, advocates, lobbyists, everyone has seemed to finally recognize that, well, maybe for communities at risk, like African American men, screening has to be smarter, has to be done potentially earlier, maybe has to be done at a more frequency than the white man who is not necessarily at risk of prostate cancer. So one initiative at the Farber led by Tim Rebeck is something called the Precision Study. And it's really trying to emphasize in the community that point, which is it's not a question of just screening, it's about smarter screening. And I think that's the number 2 innovation that I would talk about today. The third one is prostate MRI. I think as a diagnostic tool, the MRI has come a long way to becoming really a mainstay and central to our diagnosis of prostate cancer. One of the problems, and I'm sure many of you who have dealt with prostate cancer, who have family who have dealt with prostate cancer may know this, but if you have a high PSA and you suspect prostate cancer, the next step is to do a prostate biopsy. At least that's what it was a couple years ago. And the problem with the prostate biopsy is that, this is a tool that we introduced through the rectum, right? And then you take little pieces of the prostate. But the problem with that approach is that you probably oversample the part that is close to the rectum, and you probably undersample the whole part of the prostate, like the dark side of the moon, who is on the other side. And interestingly enough, there are now many studies that have shown that African American men have a much higher likelihood of growing prostate cancer on the other side of the prostate. So if you have a tool that, again, is devised for the general population, in this case, let's say white men who are at risk of prostate cancer, and you introduce the device through the rectum and you take little biopsies right next to the rectum, well, you're potentially missing some cancers, and again, cancers that are disproportionately affecting African American men. So thankfully, as a tool, the MRI has brought us more information. If you do an MRI before you do a biopsy and you know that there's an area that looks completely abnormal, now, well, we can think about going after that area and not necessarily just doing random biopsies. So the prostate MRI has been a key tool in improving our yield of doing prostate biopsies, and it's definitely going to be here to stay in the years to come. So that was number 3, right? Number 4 is, well, this is great. You have an MRI, but how do you go after the area that's abnormal on the MRI? This is something called today fusion biopsy. So like I said, how do you do biopsies 5 years ago? Well, you put this tool in the rectum, and then you go and take random snips of the prostate, typically oversampling the side that is closer to the wall of the rectum. Well, fusion biopsy is the idea that you take MRI images that are mapped, clearly telling you that this is the area that's abnormal, and then you take those images in real time and push it onto the ultrasound so that the doctor, in this case, let's say the urologist like myself, can actually go after areas of concern. So again, the prostate MRI is great, but it doesn't really help if you don't have the diagnostic corollary, which is the fusion biopsy. So the MRI was great in giving us that information, and the fusion biopsy device has allowed us to go after these areas that may have been missed on the regular random biopsy. So that was number 4. And really the last thing I wanted to talk about today is the advances in genomic testing, right? I think that one really, really interesting study that came out 2 years ago from Brandon Mahal, who's a colleague of mine at the Brigham, and that was also done with Tim Rebeck, who is the person I was talking to you earlier about the precision trial, is that he found that among African American men with a small prostate cancer, remember those prostate cancers that are better off not treated? Well, it seems like the mortality, the chance of you dying with this kind of cancer that is watched is twice as high or 3 times as high, close to 3 times as high as compared to white men. And, one way to see that data is to say, hey, African American men with prostate cancer, it can spread like wildfire. You need to treat all of them. And, maybe that's one way to see it, maybe a little bit drastic. But others have thought, well, maybe it's because of other things. And other things include, for example, not doing MRIs and then missing on those lesions that potentially carry worse prostate cancer that was missed on those biopsies. That's maybe one explanation. But another thing that people have thought about is now we have these genomic tests where you, as a patient, don't necessarily have to do anything. It's just that the sample with the cancer can be sent to a lab, and then they can analyze it and try to figure out if this cancer looks, from a purely gene perspective, worse or better than we thought. And we think, and again, this is still a hypothesis because the data is still ongoing, that maybe in the next few years, you're going to have a biopsy and you're going to have, well, this looks like aggressive, not aggressive cancer. But then your doctor may be sending the sample to another lab, have it analyzed, and then come back with saying, well, we thought your cancer was not aggressive, but we ran a couple of additional tests and it looks more aggressive. And maybe that piece of information will potentially make a difference for all men with prostate cancer, but specifically African-American men who we're concerned maybe dying at a higher rate on active surveillance. So that was really just my short talk today. I really talked about 5 innovations that I think can make a difference in prostate cancer among communities, African-American communities of color in the next few years. So thank you again for having me here today. And again, happy to answer any questions later on.
Thank you, Dr. Trin. You actually answered one of the questions I had. So the last distinguished doctor we have is Dr. Ryan Frankel. He's a urologist and prostate cancer expert at the Greater Boston Urology, Northeastern, and Good Samaritan Medical Center here in Brockton. He's going to give his expert perspective on emerging advances in prostate cancer treatment. Dr. Frankel.
Thank you, Phyllis. I appreciate the opportunity to speak today. I think this is the 4th year that I participated in this forum, so it's something I really enjoy speaking to and talking about. So again, it's really an honor to participate. So my contribution is a little different than some of the other speakers here today because I work in Brockton. I see patients at the Good Samaritan Hospital and Brockton Hospital. Our office is in Easton. And I'm the person and my partners. There's 5 of us in our office in Easton that are getting the referrals from. If your doctor is in the Steward system or the Signature system, if you get seen at Brockton Neighborhood Health, typically if you were screened for prostate cancer and you have a PSA that is elevated, typically you would see myself or one of my 4 partners. And so it really is a great opportunity to speak to you because some of you may be my patients, some of you may be my future patients. And so this education is critical. And I agree that I think that that there's really been a pendulum switch more in favor of screening and PSA screening. There was a couple of references earlier in the talk about changes in PSA screening and some physicians organizations that were not in favor of the screening, but I think we're seeing more and more studies now that are favoring early detection, which is great. Basically, I think that one of the things that many men have concerns about as it relates to prostate cancer screening is what are the outcomes going to be in regards to prostate cancer treatment? That there's there's a short step between a PSA test and erectile dysfunction, for example. And in reality, I think it's important that men know, all men, and especially since there is a higher preponderance of prostate cancer in the African American population, it's really important to understand that there's many steps that occur between the time that your primary care physician will be screening you for prostate cancer by drawing a PSA test, in the process of seeing you for all kinds of other things, talk to you about smoking or heart disease or high blood pressure. They should also be checking your PSA level. And if it becomes elevated, that's when you would see one of us. And typically you would have a biopsy, or as Dr. Trin was talking about, there's MRI options right now that are really enhancing the process of diagnosis. And then if you were to get diagnosed with prostate cancer, then there are a lot of different treatment options available, from active surveillance, where we're just observing people with cancer, to radiation, to surgery and removing the prostate. And the concern that men have about and about the kind of the adverse outcomes associated with prostate cancer treatment, it needs to be clear that that's a long step out there, and the only people that are going to receive that prostate cancer treatment are those men that will benefit from it. And that's the discussion that you need to have if you're in that situation, sitting across from me or one of my partners, about whether this is the right thing for you. But the knowledge is critical, because if you don't have that PSA test to start, we're never going to be in the position to have that discussion. And so I think the number one thing I want people to take out of this, of my talk, is to understand that you probably have heard some of the bad symptomatic results of prostate cancer treatment, urinary problems and erectile dysfunction. And they're scary, and they're scary to me too. And that's why, you know, those of us in the urology field really want to save these arrows in our quiver for those men that are truly going to benefit from it, where the risks of some sort of side effect associated with the treatment of prostate cancer are outweighed by the benefits, because you're going to live longer. But those men that have a much lower risk of dying of prostate cancer are not going to require those same kinds of treatments, and therefore suffer the same kinds of adverse outcomes in regards to urinary function and erectile function that we all want to see men avoid. So, you know, it really is a pleasure to be here tonight and to talk to all of you. And again, Phyllis, thanks for having me invited tonight. Thank you very much.
Thank you, Dr. Franco. That concludes our presenters tonight. I want to thank them again, because they all gave their expert opinion about everything about prostate cancer. And to all the people who are attending, I hope you will take away from this program, because it is some very important information that you should have. Before we go into our Q&A part of the program, I would like to take this opportunity to thank our team for putting this together. We have the team from AdMeTech, that's Dr. Stern, Thomas Sathan Passett, and Alexandra Adam. We have from Good Samaritan Hospital, Lynn Cornelius. And we have the Brockton Committee, Health Committee, Janet Trask, who is the chair. We have Leona Martin, Steve Bernard, and Mark Lindy. I want to give a special thank you to Steve Bernard, who was instrumental in bringing all those churches on board to listen to this very educational program. And to Mark Lindy, who did the marketing for the program. He did an outstanding job. So thank you, team. You did a great job. So at this time, I'm going to turn the Q&A over to Thomas. Thomas is a manager of office operations and health policy at AdMeTech, and he just recently received his master's in public administration. Go, Thomas. So Thomas, take it away with the questions.
So we have a couple of questions from the chat. So the first question is, and anybody can, any of the medical professionals can answer this, can jump in. How often should a man get screened for prostate cancer? That's the first question that was put out there. So anybody that wants to come out there to answer it can answer it now.
Trink, do you want Kwok, do you want to address this question?
Yeah, sure. I mean, it is still in flux and somewhat of a controversial question. I think the age categories, we nailed it down a little bit earlier. 55 to 69, 55 to 70 seems to be the age range and where we generally consider screening. And then we feel that if you are African American or have a strong family history of prostate cancer, probably started earlier. In the past, generally guideline panels have recommended doing screening on a yearly basis. I think that as the science evolves, it's been a little bit more controversial. People think that you may do it, on a less frequent basis. But it also has to be adjusted to the case. I'll give you an example. If your PSA is borderline high, but you and your doctor have a conversation and agree that maybe we're just going to watch it for now, you're probably not somebody that I'm comfortable waiting another 2 years, right, before doing another PSA test. Maybe that person, we're going to check it again in 6 months. So I guess the answer is it depends. I think their age category seems to be getting a little bit more to a consensus. How often you do it depends on your family history, your race, and also your personal history of how your PSA has been evolving and how concerned I am as a urologist about your chances of having cancer, for example.
Okay. Thank you, Dr. Trin. Second question, we got a couple more questions after this. Can anyone address the potential passing of prostate cancer to children, the younger generation, when they get older? Would you recommend DNA testing to see if it can be genetically passed down? Anybody that wants to answer that can take the floor now.
I mean, it's a loaded question. In general, when you say that a close relative who has prostate cancer increases your chance by twofold, two relatives maybe fourfold, to have a chance of having prostate cancer. But it's not like all prostate cancers are equal when you try to think of the family history. For example, I don't know if a lot of people know this, but if you take people in their 80s, more than half the male population actually has prostate cancer. They just don't know about it. So when a patient comes to see me and tells me that my father had prostate cancer at 85 and died of natural causes, that's less interesting from a medical history perspective than if you told me that my father had prostate cancer at 45 and passed away at 46, right? So it's not all equal, that's just the general rule. But, obviously if you come to me and you say that 3 of my uncles and brothers or whatever had prostate cancer, I am highly suspicious about, your risk of having prostate cancer. Now, with regards to genetic testing, that's also controversial. The reason, there's many reasons why it is controversial. For one, we don't want to do genetic testing unnecessarily, right? If you start doing genetic testing on every single person, suddenly you find things that you weren't even necessarily looking for. You don't know what to make of that information. And it can get quite confusing. And what I mean by that is that there are some genes we are certain that you are really, really high risk that you'll get prostate cancer. The BRCA gene defects, things like that. And that, I think, today affects our medical decision making. If you have this kind of genetic mutation and you have prostate cancer, we may not feel as comfortable about the idea of surveillance if you have a really high chance of getting a bad prostate cancer. But usually when they run these panels, they're going to run a bunch of other genes. And then you'll have a gene that says, well, sir, you carry this and this gene, and that gene increases by 1.5-fold the chance of having prostate cancer at age 65. And then seriously, what do we and you as a patient do with that piece of information? It's unclear. And to add to that confusion is think of all the ethical and legal consequences of you getting genetic testing. Now suddenly you think you may have a gene that could maybe have caused prostate cancer and some other cancer. You may have passed it to your son. What are the consequences for your son of getting life insurance? It gets a little complicated, but I think that most people in our field, we feel like if you have a strong family history, there's probably a benefit in getting that kind of test, because that's information that is extremely valuable that you want to pass to your children, and that outweighs potential risk of not being able to get life insurance or something like that. So yes, in some cases, but be careful about getting it in everyone. That's my long answer to a short question. I'm sorry.
I'll just sort of weigh in a little bit on this question as well. And there really has been a major growth in the alternatives and opportunities for all kinds of genetic tests. And the types of genetic tests that are available include both tests that you would do, like Dr. Trin was talking about, with all kinds of different genes that you're looking at, be a blood test that you might do. And then there's also genetic tests that are being used on the prostate cancer tissue to help you identify, based on some pathologic finding that a pathologist will describe when they see, that make the cancer look less aggressive, and some genetic findings that'll make it look more aggressive. And I think some of those tests are very helpful to try to help us decide who should get treated, who can we watch, and I think that's very important. Some of these genetic tests, however, that are really looking at all kinds of different genes and trying to assess people's risk for all types of different cancers, I think it is sort of a Pandora's box at times. And you may find certain results that are not helpful and can be hurtful. As it relates to prostate cancer specifically, however, we have pretty good standards of how people need to be screened. You know, Dr. Trin mentioned 55 to 69. I think that that might be a little bit too small of a category, particularly in some of the at-risk groups we've been discussing. And as long as we're executing screening strategies along those lines, I don't know that there's a lot of benefit to just drawing someone's blood and looking for thousands or hundreds of genes that may increase someone's risk of one form of cancer or another. So as a general rule, I think just indiscriminately drawing genetic testing could potentially have more harm than good. But certainly there's certain genetic tests that are specifically honed on identifying who is at higher risk of a more aggressive prostate cancer that can be very useful.
I would like to emphasize how important it is what Dr. Frankel and Dr. Trink just discussed. And if I turn the question into a practical advice, that this conversation clearly showed that if you are concerned about family history of prostate cancer, ask your physician to be referred to an expert, particularly urologists like Dr. Frankel and Dr. Trink, and to discuss with them whether or not for you as an individual, genetic testing is going to make sense.
Since we're all getting a little low on time, we have one question left. What is the probability of someone who's had prostate cancer in the past have it come back? And if so, how aggressive would the treatment needed to be given that the options are always changing?
Dr. Frankel, would you like to comment?
Yeah, sure, I would love to. It's a very complicated question because prostate cancer can recur under any number of different circumstances. It also depends on what kind of treatment you receive, if any. And what I will tell you is that what is really exciting about the world of treatment, and in particular in the world where we're seeing recurrences, where people have had treatment and still recur from their cancer, is that over the past 10 years, even 5 years, we've really had a lot of developments of all kinds of new drugs that are helpful in this area. So people that might have had their prostate removed or had radiation for prostate cancer, and then they have a recurrence where it looks like the prostate cancer has come back. It used to be that we really had limited choices as to what treatments we could offer. But over the past 5 to 10 years, the number of treatment options has grown dramatically. And therefore, I think we're in a much better place to keep people alive for a longer period of time when they do have these recurrences. And I think this is a very positive development that can give people some solace when they do learn that they are having a recurrence.
I believe you also had a question about how frequently African American men are screened vis-a-vis white men. And the latest data, I heard what Dr. Trink said already about rising probability of African American men to be screened. The last data I saw, Kwok, was from 2019-2021 American Cancer American Cancer Society's Cancer Facts issue. They said that Black America, at least as of several years ago, Black men, about 31% of Black men were getting screened who should be screened, and about 37% of white men. Would you agree with these numbers?
So the numbers, they're skewed, in my opinion, because there are studies that have, like if you look at it a little bit more in detail, it's skewed in the way that there's a lot of more white men who are older who are getting screened compared to African American men. But if you look at the age category of 55 to 69, for example, or let's say 50 to 60 or 50 to 70, there's slightly, barely, but slightly more African American men who get screened in that age category, which is the age category that we're most, I guess, focused on. But there's definitely significantly more white men who get screened at the older age category, which makes the numbers skew towards higher rates overall.
Thank you. Another question we had was, did PSA screening decrease significantly during the past months of the pandemic? Dr. Fish, would you like to comment on that?
Thank you, Faina. I think Dr. Trin actually beat me to it in the chat room there. And he's posted a link to NBC News where he did a response to that question. And I'll turn it over to Dr. Trin.
Yeah, no, I mean, we did study this with some collaborators within our health system, and it's pretty staggering. It's like we found like more than a 60% decrease in screening during the pandemic months. We looked at a number of cancers, and in our health system, it's like close to 1,400 cancers that are potentially missed during the pandemic months in our health system, and that's 1,400 in Brigham, Mass General. Imagine how many it is if you extrapolate to the country. And I think that in sync with our topic of discussion today, the concern in this follow-up study that we're going to publish that's going to come out soon is that, unsurprisingly, the people who are going to miss their screening were not educated, people, white males from Newton or Brookline. It was more likely to be, minorities who were potentially less likely to be screened, because remember, during those months, what happens is that most of the communication with your doctors had to happen via telemedicine, and telemedicine requires you to have a computer, set up Zoom, be able to go on the portal, do all that stuff, and then we definitely lost a lot of people, and we lost people who couldn't connect, couldn't get onto this platform, and as a result, they were not getting screened. And there are obviously downstream consequences that we're only going to understand 3, 4, 5 years from now when we see the actual damage that was done from the pandemic.
I don't see any other questions. So,
if I may, Tom, I just got one quick question, and I know we're pressed for time. In regards to testing and so forth, and my doctor's been great, but sometimes because of whether it be for prostate or colon cancer, sometimes they don't ask you about getting tested, especially if there's a thing in your family. You have to communicate with your doctor, but in with MRIs, if they're mentioning about doing that rather than the traditional up the rectum test for prostate, is there pushback from insurance companies? Because even with MRIs, they want you to do that. Sometimes the last alternative when you get a sports injury, like, they do x-rays before they do MRIs. Is there any pushback from insurance companies that anyone's hearing from?
Yeah, I can speak to that. There certainly is. I mean, unfortunately, although it's a reality of the healthcare system, lots of decisions that we make, be it in prostate cancer or otherwise, are certainly influenced by what the insurance companies are willing to pay for and under what circumstances. You're right, actually, when you tie it into sports injuries, because it actually is very similar to prostate cancer diagnostic testing. Typically, as far as the private payers go, Medicare is a little different, but as far as the private payers go, most of the time, insurance companies will not pay for MRI tests, prostate MRIs, as a test looking for screening for prostate cancer, unless someone has had a prostate biopsy, first traditional biopsy what Dr. Trin was talking about, where they sort of preferentially favor tissue that's close to the rectal wall. And that's just kind of the way payment from the private payers is right now. I mean, MRIs are expensive. I think there's a concern that there would be too many of them. So it's a complicated question for sure. But yeah, just like in sports injuries where people, really have to struggle to get an MRI, if someone has an elevated PSA, it's very, very difficult to get an MRI prior to someone having the standard prostate biopsy.
Let me just weigh in for a quick second on that, and it comes back to the word advocacy, but advocacy on two levels. One is you as an individual need to really press your doctor again and again about what you need, what you want as an individual, and it's not necessarily pleasant. We're not used to doing that. Sometimes it helps to have a spouse there or a partner there to help with that, but as an individual, you need to press for what you need. The second is advocacy at a higher level with specifics to, and particularly with the representatives that are on this call with us, to really hold the insurance companies accountable for stepping up their game and providing more service, not less. There is an old saw in the diagnostics world that insurance companies will reject everything until there's enough grief with them having to do one-off reviews and subsequent approvals. When the volume of those reviews and approvals gets to be so large that they're spending more money on the rejections and the approvals than they are on simply paying for the test, that's when they begin to pay for the test. So there does need to be advocacy for things that are good, like prostate cancer MRIs. Medicine changes over time, and it changes because the data gets better, because there's dissemination of that knowledge, and because insurance has to catch up to what the standards are as advocated by the doctors. So we have to advocate at two different levels.
And the irony is sometimes it's less expensive in the long run to do the testing early to prevent the further diagnosis down the road. And you hit the nail on the head where till we get to that point. We've passed some legislation in the past, but if there's anything you recommend, I know Rep. Dubois and myself are on the line, but we can convey this to our colleagues. Please don't hesitate to contact us regarding that, because we're constantly looking at keeping costs down, but also protecting the health of our constituents, which is the number one priority.
And this is the key point. AdMeTech Foundation has been leading development of MRI and creation, actually, high precision MRI since 1998. And what we've seen repeatedly is, yes, MRI is expensive, but it is much more expensive to do unnecessary biopsies or to do biopsies that miss prostate cancer and end up with advanced and treatment at least 10 times more compared to early prostate cancer. So what Senator Brady mentioned, it is important for us to look not only from a standpoint of the cost of a diagnostic study, but the impact of this diagnostic study on the entirety of patient care cycle and the costs of the patient care cycle. And I know that we are 3 minutes over. Phyllis, I will turn it over to you.
Okay, this has been very educational and informative. I want to thank all of our panelists, our special guests, our committee, and all the attendees. I know you're going to walk away from this program with some information that you need, and you're going to go to your doctor and get tested. So thank you all again. We have another event coming up in September. Hopefully the doctors on this call will come back in September. We will be reaching out to you because you all were outstanding. Thank you, everyone, and we will see you soon.